I see associated with those three diagnoses. Objectives are pretty clear. We're going to learn about the clinical assessment for these three disorders, the latest guidelines, and then evaluate our own practice. One thing I found while doing this lecture, which I highly encourage other people to do, things sometimes you're doing day in and day out, and then you go back into the literature and you think, oh, I could be a little bit better in questioning why I do some of the things that I do. So I guess there's always a little bit of a benefit to doing presentations like this. We're going to go back briefly to vehicles. Remember last week we talked about vehicles, and I cannot tell you again the importance of knowing your vehicle when you put a topical on someone, because you can make or break the treatment plan for them. And oftentimes if you don't think about what vehicle you're using, you may not even get the results that you want, or non-compliancy will be very apparent. In dermatology, personally, I use gels, I would say 90% of the time. The other 5% I would use creams, and on a rare occasion I'll use a lotion. And usually the lotion is because another provider has ordered it and it's worked well for them, or they have really, really sensitive skin, or you're doing it in a hair-bearing area. Solution, I can't recall the last time that I've ordered a solution. Clindamycin and erythromycin both come in solutions. They're hard to put on, they're not covered by a lot of insurances, and I think a gel actually works better. So if you're one of those people that are ordering solutions for acne or rosacea, you might want to think a little differently about the applications with this product. And an ointment, I can't say that I've used an ointment for any rosacea. I don't think I've used it, but I know that it's out there, so I listed it. So going to your handout, you'll see one that has a sebaceous unit sitting there. And we're going to look briefly at that just so that we understand some of the terminology, so that when we make our decision making about acne, we need to know what we're looking at. And oftentimes what I see individuals who put someone on an oral antibiotic when all they have is comedone acne. So you have to know what a comedone is, what a papule is, what a pustule is, and what a nodule is. And so when you're looking at your patient, you've got to think that way. You can't just think this is acne and go for the standard tretinoin and an antibiotic and send them out the door, because you may have created a treatment plan that probably wouldn't even work for them. So looking at your diagram, let's sneak down here, you'll see what a hair follicle looks like, and Greg, you must look at these a lot.
Oh yeah.
And the biggest thing is, we're going to look at this like a carrot. And at the top of the carrot, before it pops out, that's the top of your pore. And you've got to get that opened up, or you're not going to have good results with your acne care. And what happens is that gets plugged up with dead cells. And what happens oftentimes, and if that isn't cleaned up, then you're going to start getting some of your inflammation, your infection occurring, your nodular cystic acne, and events like that. So if you see somebody that has acne, and how I describe it as sandpaper skin, take home message, comedone. So if it looks like it's kind of bumpy on top, and maybe you see some blackheads and a few whiteheads there, that is a comedone until proven differently. And a dilated comedone is a blackhead. That's all it is. And what's nice about that is it's probably working itself out a little bit more than what the whitehead is. So let me go back here, since I see how do I go back.
Which slide are you on?
Oh, keep going, thank you. Next one, there. The next thing is a papule, and how I describe a papule is about 5 millimeters raised skin. There's no zit to pop. That is a papule. So you could have a comedone with a raised area, and that is papular acne. And then if you see something you'd want to pop with a little pustule on top, that is considered a pustule. And then the last thing is a nodule, and how I describe that is something firm under the skin. It's greater than 5 millimeters, and it can be with or without erythema. And then within the nodule, sometimes it will soften up and create a little bit of a cyst-like, and that is considered a cyst. So when I describe acne, I'll say there's comedones, papules, pustules, and nodules. So then I can justify my treatment plan, because if I have just put down has acne and wants it treated and not under the skin exam, it's hard for me to tell down the road what really was going on. So that's kind of how I go about it. I'm not saying it's right or wrong, but it makes it a little bit clearer for my treatment plan. Thank you.
So you should be able to just use the wheel on the top metal.
So don't even use mine at all.
No, just, well, I guess you'll have to do it both.
So I'll go here for me, and then do I have to do it here too?
Yeah.
And that will advance it. You know what, I think I want to go back.
The wheel should just roll the front, go back, and it'll.
Yay, we'll see. Okay, so the thing about acne, it occurs when there is a change in that top layer of the pilosebaceous unit. And this becomes dense and blocks, and then we have these little time bombs, which are called comedones. And I see oftentimes that the time bombs aren't taken care of. Let me see if I got this right. Here and here. Oh, I didn't advance up here.
Roll the wheel on top. Yep.
Oh, wheel, okay. So going to this, I'm just going to look again at our diagram. Where you look at the picture and right below it are the little red dots, so to speak. That's where if you see a bacterial effect in your acne, you'll obviously see a little bit of redness there. And you start thinking about ways of getting rid of the erythema or the infectious process. Number one, benzoyl peroxide. Think of benzoyl peroxide as a medication that's going to help kill bacteria before you go to a topical antibiotic. Then, of course, there's oral antibiotics, and then the last would be isotretinoin or Accutane. Now, when you think of inflammation, I think of inflammation really bad is if I can take a lesion and kind of palpate it and feel a pea size there, that's significant inflammation. And what I do for that oftentimes, if it's just an isolated one and they have a special event coming up, I will inject that with Kenalog. I think back to the time in the emergency room where a bride came in and had one, and I didn't know this at the time, and I didn't do her a service because she could have had that lesion injected and probably made her day a little bit better. I just thought, you know what, you're going to have to deal with what you have and move out the door. And I think about that today if I had known that, yes, you can inject a lesion. But take-home message from that is you have to be able to palpate it and feel it. You can't just go into a real vague red area. Because what will happen there is that Kenalog that's injected will go into the soft tissue and you'll cause dimpling of the skin. That will usually resolve though. And then the other thing, if you go to the right-hand side on this picture, you'll see where there's a sebaceous gland function area, and that's where we would use the birth control pills, spironolactone, and actually Accutane will help that as well. When you see a rupture of the follicle wall, where you see on your left-hand side, that's what oftentimes will occur with sebaceous, with nodular acne or cyst-type lesions. I just got this right now here. So history is really, really important, and I kind of feel like a drill sergeant. I know my friends will sometimes say, I can't believe how many questions you can ask in a short period of time. And I think that's from living in this healthcare environment, because we really do drill. First thing I ask is, when did it start? Where's your location? What makes it better or worse?